So we shall start. Now, this is one of the cases that I put in the, I think it was case 17 or 16 or 17. I think there was one put as case 18. So I like what you can see here. So this is one of those cases, and basically this was an antral or stomach polyp, and in a middle-aged patient, and then basically what it is that we will be talking a little bit today about some polyps that does come in the exam, and some of the polyps that most likely are going to come as well in the exam. So we will be spending sometimes with these polyps, and this was a special request from some of you that I will respond to. So completely different areas. It is GI pathology. Now, we'll start with this one. Okay, so don't get excited when you see a polyp. Just, first of all, identify the shape of this polyp. And if you feel that this is a polyp has got a stalk, or does it look like a sessile polyp, which is a little bit more flattened, because a lot of the differential diagnosis and the interpretation will rely on how you do see this polyp, okay? So this is number one that you need to be aware of. Number two, don't underestimate the surface, because in some cases the surface can give you a clue. So do not underestimate what you see on the surface, and then you can see that this mostly contain what we call it a non-specialized type gastric mucosa of some sort. So we are in the right place, and that's absolutely fine. I have a simple question for some of you. What I wanted you to tell me is, it's a very simple question, but a lot of us don't think of it. And it had nothing to do with the polyp, but it just came to my mind now. And the question is, how many or how much inflammatory cells that you need to see in the stomach lamina propria in order to diagnose inflammation? And I'm talking about the chronic inflammatory cells, not the acute. So can you give me any figures? How much? Similar to small bowel? Much less than small bowel? Similar to the esophagus? How much? Just guess. All right? Even if you don't know the answer for this question, just give me, guys, just write any guessing. Okay? And don't be embarrassed, you know? No one will remember what you're saying when they wake up tomorrow morning. So just guess. Let me know what it is. Just write in the chat room. What do you think? How much inflammatory cells are needed to diagnose chronic inflammation? Some responses, please, so we can move on. More than the esophagus and less than the small bowel. Normally, stomach has less inflammatory cells than small intestine or colon. Okay, any more? 3 to 5 cells. So some of you wrote 3 to 5 cells. Plasma cells more than 3. Excellent. So some of you know the answer for this, and this is a very important concept when you assess any biopsies. Okay, so it is about the clustering of plasma cells. If you see a cluster of plasma cells at 5 or 6 cells, like what you see here in the middle of this field, then that means that you have some elements of chronic inflammation in the lamina propria. In ideal situations, you are right, you get nothing. You know, like a field like here, where in these areas here, let me just put these spotlights here. This is your lamina propria, no inflammation. just endothelial cells. But if you start getting clusters, like what you see here, like what you see there, then this is a chronic inflammation. Okay, so remember that. Remember, you are not supposed to see any inflammatory cells in the lamina propria and the stomach, and this is the norm. Now then, let's go back to our polyp, because we are today in the polyp. It was just a question that came to my mind. Now, the relation of this polyp, it's very clear that you went through the epithelium. It looks okay, not particularly exciting in terms of hyperplasia or in terms of dysplasia. And then we go down, and most of the polyp appears to be filling in the submucosa. So this is a submucosal polyp. So the location of the polyp is quite important, because some polyps in the GI tract, like if you have, for example, schwannoma, if you have a leiomyoma, and if you have a GIST, they tend to be submucosal. And then this will give you a very good category for what you might be thinking of, all right? So I'm starting with the most easiest one, and it is a kind of like a spot diagnosis that does come in the exam. And for those who have seen it, they will know this polyp very well, like they saw it in the collections, which we put it in the first lecture online. For those who did not see it, then you have the chance now to see it. So I'm slowly increasing the power as I am going along the polyp to show you how it is, what it looks like. And I shall stop here. I just need the diagnosis now. This is very simple and easy. So some of you said schwannoma, some of you said inflammatory fibroid polyp. Any more? Right. Okay, fine. So this is the easiest polyp that does come in the exam. And it is basically, you see the scattered eosinophils that will catch your eye. You can see them everywhere. And then around the blood vessels, you see some whirling or onion skin pattern around the vessels. And you look back, you see the polyp very vascularized, variable caliber vessels scattered throughout, even very large sinusoidal-like here. So this should, and sometimes you see the surface intact, sometimes you might see the surface ulcerated, but it is submucosal polyp. And when you stain the epithelial cells around it, or these constituent cells, it is basically, the constituent cells will be CD34 positive. It tends to happen in the stomach a lot, and sometimes in the rest of the small and large bowel, but stomach is a very good site for it. It is absolutely completely benign, and excision is curative. This is what you need to write in the exam, you know? You need to write that the stomach is a common site. So you did your clinical pathological correlation with the age and with the site up. It happens in the middle age, so you correlated with the age. You then say that the prognosis, the fact that, and what next treatments online might needed for this. All of this together with the immunohistochemistry should score you. In my opinion, if you write all of these things, yes, absolutely, you can write also the mutation if you want, but who will do a mutation on a fibroid polyp? Are you? So you're not going to waste the money of your department on this, yes? So just be careful again. In the information that you put, you say, although not needed, but this polyp has been shown to show this, okay? So you just be intelligent as well, how you put it, because if the examiner is to read it, that I will do this mutation because this polyp show this mutation, then it will be difficult. It is different if you are dealing, for example, with a liposarcoma, or you are dealing with a synovial sarcoma, and you are going to put mutations because it's very important for the diagnosis. Yes, and exactly, and this can present sometimes with the intussusception if it is in the small bowel. So all these informations which you guys are sending, these are very useful, but fibroid polyp, the maximum you will score possibly 3, if not 2.5, because this is a spotter case. And we talked about the spotter cases, and we thought, okay, that the spotter cases are the cases which are not going to score more than 2.5. All right, so we consider them the easy cases for the exam, but unfortunately, it makes you lose 1 mark of what you need to score. You might think, well, that's madness. It is actually, but this is what it is, right? This is what it is, right? That some cases you won't score more than what that more than what you will be scoring. So these are these things, okay? So I just wanted to warm you up for this polyp, and then I'm going to take you to this one. Okay, so this is a right side. So so sorry, there was a glitch, misconnections. I think we are all back now. Are you all okay? Are you all back? Okay, good. Right. So let me just basically show you this. And this is a colonic polyp in maybe a 55-year-old. Okay, and I wanted to show you all the pieces that we've received from this polyp. And I want you to now to tell me, what do you think? Okay, I don't want you to jump for diagnosis, because you need to learn not to jump for diagnosis, and this is very important, because if you don't have that skill, then you're probably not ready for the exam. Okay, so this is one thing that I wanted you to adjust and adapt yourself. Think before you talk. Okay, so this is a very important skill for the exam, because if you don't think before you talk, you will get 3 cases wrong in the exam, and that will fail you. You're only allowed 2 wrong. Right, so let's see. I'm just going through this medium power now to all the pieces. You can see how the polyp can be very time consuming. Okay, some of you said that you have a lot of fat in the submucosa. Okay, lipomatosis can happen in the submucosa, and if you don't see anything else on the surface, then sometimes you can suggest it. And sometimes in cases of intussusception, all what you see is fat in the submucosa, but that is not what I am after. Some of you said that they started to see some serration. Good. I'm going to go to a little bit higher power here. And I choose this polyp because I will be able to show you a lot of things in it. It's a beautiful polyp. I can spend maybe the next hour talking about it, but we will try to make it quick and less painful for you. Right, let's stand by some areas, and I wanted to see what you think. So there is serration, okay, but there is no dilatation of the crypts, and it looks here like cone, a little bit like a cone. You will put your hot things inside it, yes, so that's like a cone, like here as well. Can you see this triangular bit of the crypts? So which means that probably these areas here are not serrated, and this is important, and I will highlight that in a minute. The other things as well, that the serration is not very long, okay? So some of you are suggesting hyperplastic polyp, which is good so far, okay? But just bear with me, right? If I don't convince you about what we are seeing in this polyp, you can throw me out of the window and never listen to me again. But let's just see how I approach the polyp. I'm showing you how I approach a polyp like this, okay? So I saw these areas, which is fine, but keep sending you suggestions. I'm not stopping you guys from sending you suggestions, but what I want you to see, that the lumen is still open, and it's still irregular, and some people call it like Mercedes car sign, you know? Some people call it like this sometimes, but anyway. So serration, some goblet cells, not a lot, but this is a problem of the case. And the problem of the polyps that it can come fragmented and in pieces like this. This is the area which some of you felt it might be lipoma because they saw that the crypts here are fine and they are not showing any features to worry you at all. Slightly start to become here cauterized and maybe hyperplastic, but we will ignore this. And then we have these areas, which is a little bit different because you start to see more dilatation towards the length of the crypt. So if you go to the surface, you see that there are some dilated crypts on the surface, and as you go down in some areas, this dilatation now has finished. Don't forget that the base of the crypt here, it is in continuity with this crypt that's quite dilated up here. So this group of crypts are the base of these crypts up here, and that means that these crypts are cone-shaped because they are dilated up and they are very narrow down. And when you go to the base, the lower 1/3 of the crypt, there is no serration, and that does put these areas with the serration up and the dilatation in the hyperplastic category. But that's not all. I will keep moving, okay? And I'm going to take you here. Now the story changed. Look, the story has changed because what you can see, that the serration on either side, it is actually what you can see, the base is the nuclei, and then all of what you can see in the middle, this is serration, this is mucin, okay? We are in the large bowel, so don't mix it up, okay? We are in the large bowel, so fundic, this is large bowel, this is cecum. For those who did not listen to the history, this is cecum, okay? So let's just analyze this script here. these crypts are different. In order for you to understand the epithelium in these areas, what it is doing, I will take you to another area in this polyp and I will bring you back to these areas. So just bear with me and you will understand the entire story, and you will be challenging everybody else again in the future. Now here, what's happening here, right? Look, there is serration. We know that this is part of a hyperplastic things, yes? But we are in the base now. This is the muscle, okay? So the serration is present in the base. Can you see that? Now, the epithelium on either side is reaching each other. They are like kissing. The lumen is very narrow. Can you see how narrow this lumen is in relationship to what you saw in the area that we call the hyperplastic? I will show you a quick comparison. Look, the mucin, the apical mucin in these cells is very high, up to the degree that it does like kissing from both surfaces and providing these very narrow lumina, and they are present at the base, just on top of your muscularis propria. Okay, let me take you back to the other areas which we felt that they're a little bit hyperplastic alone. Look at the lumen here. Okay, look at the how tall these cells are. Now, these cells are not as tall as the cells which we saw. The crypts in the base has got this lumina, which is nearly as patent as a normal crypt. Okay, so let me now take you to the area that I'm interested in to show you, which is, I think, this area here. Yeah, that's the one. Okay. So this is the area which I'm interested now to show you. So printing this apical mucin in your mind that they were touching in the middle. So all of what we see here is serrated epithelium, which is going all the way down. And the reason why I know that, because the crypt is still dilated at the base, and in actual fact, it's actually getting slightly in some crypts more dilated, like here, as you can see, which in hyperplastic polyp is the opposite. The crypt or the cone shape will be the opposite. This is now getting dilatations all throughout from top to bottom, but the base is wide and it is dilated. So this is one element of the equation. But it is not only that, you tend to get this angulation as well. Can you see the angle of the crypt is a little bit changing, okay? And on the last, in the TS view, and here as well, I can tell you that the muscle is here, but you are able still to see serration at the very, very base of this crypt. And this is a little bit different from your hyperplastic concept, because the lower 1/3 should be fine and clear. But not only this, they tend to say that the crypt as well can start to become a little bit more horizontal. You know, like the crypt will start to become a little bit parallel to the lamina propria. But one very interesting feature, which we can also see in this polyp, is this. What on earth is this? The muscularis propria is here, and look, the crypt is trying very hard from its base to go through the lamina propria into the submucosa, which is also an important feature, because normally you do GI biopsies like myself 100 times a day, and normally the crypts should stop by the muscularis propria. They touch it, or they stay a little bit short, very slightly short of it, like here. This is a normal crypt here, so it should, you know, you get this tiny weeny, very, very minor space here, or sometimes it touch, which is fine, but it shouldn't go through, okay? Like what we saw in some crypts, like here, look, the muscle is here, and the crypt is trying to indent now into the muscle. And in some cases, like here, you can see the muscle is cut by the crypt, okay? So the muscle is cut by the crypt. This is not right, okay? This is not right. So we have a constellation of features, starting with the serration, very tall mucinous epithelium, and the crypt dilated even toward the base. The base of the crypts are dilated. Some of the crypts will bifurcate, giving you this inverted Y shape. Some of them will bud. Can you see this budding here? Okay, which is not features that happens normally or you take it lightly, because that means that this is a very dividing epithelium trying to create a space by creating all these buds. Some of the crypts are angulated in order to become horizontally orientated. You know what will happen to this? This will become now parallel to your to your muscularis mucosa here, which is not right. Again, here you can see that parallelism. This part of the crypt is trying to become parallel to the muscularis mucosa. This is what we call it now, sessile serrated lesion. Exactly. Some of you said T-shape and boot shape. Exactly. That is a sessile serrated lesion, or we call it sessile serrated adenoma. Now, you know, before the WHO that came last year, there was a lot of debates about these type of lesions and how we are going to call it, and the British people call it this way, the people from America call it a different way, and if you guys from trying to follow the both system, then you are in a dilemma. So now the WHO say that you can call it either, providing that your clinician knows what you mean. You can call it sessile serrated lesion, or you can call it sessile serrated adenoma, and they both now mean the same things. Now, some of you said sessile serrated lesion with dysplasia, not seen here. This is an upgrade, okay? I did not assess for dysplasia. If you assess for dysplasia, that's fine. You call it sessile serrated lesion with dysplasia. I will show you these classifications in a minute. But what I wanted you to understand about what I have just been explaining and going through, that you have to apply them all together. You have to see many of these features. If you see only crypt bifurcation, that's not enough. That can also happen in a hyperplastic polyp, okay? And if you see only budding, that's also not enough, because it can happen in other conditions. You need to see these dilated crypts, you need to see the angulation, the horizontal alignment, you need to see the serration extending to the base, you need to look carefully to the height of the epithelium into this, and then after that you will be able to say, okay, sessile serrated lesion or sessile serrated adenoma. You use either terms in the things, you will be absolutely fine. Now, don't think, don't be focused. I saw a lot of cases of, you know, in the fat obese people, they can, I can be penalized for using these words now. Okay, for slightly overweight people, okay, you can see some accumulation of fat around the bowel a lot. When you do the large bowel dissection, you see plenty of fat, of course, and omentum, but you also can get accumulation of fat in the submucosa in the large bowel. So providing that it is diffuse process and it's not particularly localized, then I don't pay a lot of attention to this, and providing that you have the other more major pathology into this, that's fine. So I just wanted to take you quickly to this. This is the WHO classification, which you can all see on the screen now. I just borrowed it so I can show it to you from the WHO book. And what you are able to see, sorry, yeah, here we go, that you have I'm just trying to, sorry, I have a lot of windows open, so I'm trying to move them so I can see what I'm talking about. Okay, so what it is that you have this, your hyperplastic polyp, the classic one. You know, they didn't put a lot of descriptions, but you can see that this is now the hyperplastic polyp. The hyperplastic polyp, some of you ask which one can come in the exam. Well, any really, but I have a strong feeling and that the Sessile serrated lesion or / adenoma, they will come in the exam because they have been now officially verified last year in the WHO. And when I went to some GI conferences and courses, the only talk was about this. So because the GI people don't deal with a lot of varieties of things, no, I mean no offense, but it is usually adenocarcinoma or GIST or adenocarcinoma again. But what it is that then this was a very exciting areas to highlight into this category. Now, the Sessile serrated lesion, or if you want to call it Sessile serrated adenoma, is this guy here, and if you start to get a dysplasia, then you will call it Sessile serrated lesion with dysplasia, which will basically show the architectural feature of what we saw in this, plus dysplasia, plus the classic dysplasia that you see in the traditional, not the traditional, sorry, with the classic dysplasia that you see in tubular adenoma, or you see it in the what is the vellus adenoma, you know. So these are the things. And then we also had this one, which a lot of people were not paying a lot of attention to, but they did find out that it has got some KRAS pathway mutation, something that we call it goblet cell hyperplastic polyp, goblet cell rich hyperplastic polyp. And then we have the traditional serrated adenoma as well, which is it's a little bit different. And what it tends to happen, it happens more on the left side. And while the Sessile serrated lesion has got the more tendency to happen on the right side. You can see that the two pathway, either BRAF or KRAS mutation, they are different between the two. I'm not going to go through a lot through this, but in the WHO as well, you will find that you have this diagram, which is you have to know it very well. Okay, not only that you will write it for your brownie point, but you have this written OSPI which is a station in the FRCPath exam. And historically, they tend to ask you sometimes about the BRAF and melanoma implication on therapy and what it means and what it is. So what you need really to do is to get a paper about the melanoma molecular recent advances in molecular for melanoma, to study the BRAF for melanoma. So this is the very important area. This is your second area that you need to understand the mismatch repair and how it works for some of the problems. And then you need also to understand the WNT pathway, because you in the written OSPE, they will tell you what are the main genes, what does it mean, what it will lead to, and what are the common conditions that can be found in this. And then you need to be aware of these questions, or otherwise it would be very weird for you. So you need the mismatch repair and the adenomatous pathway of the normal development of the cancer, but you also you need to know the sessile pathway for developing the cancer. So this diagram is very important, because then you can say that that some of the adenomas, the sessile serrated lesion here, which is the right side, it has got a different pathway molecularly from this pathway on this one. Okay, so both of them, all of them can come in the exam. Okay, so just be aware of these pathways, and you really need to get the most recent paper. You will find it in the Journal of Histopathology. I think they had in the last few months, they had a very recent paper about the sessile serrated pathway, because this pathway here has got what we call it traditional serrated adenoma, which is a little bit different from our sessile serrated lesion. And I am going to show you that in a few minutes. Okay, so let me just go back to what we were talking about. And this is another polyp now. You see, you will either hate me or like me after this lecture, so it all depends really on how strong you are in this polyp. If you're very strong, you say, well, a waste of an hour. But if you're not very good in it, then you might then be happy with what we're talking about. Okay, but it is a very interesting areas, and we really have to try to hammer it into this session. Okay, so let's just discuss this polyp now. I will stay in this medium power, and I wanted you to just follow me. And I want you to just not to jump for diagnosis, because you need to be more in control, okay? And then we will open the gates to give you the options so you can start talking about it. Now you know that in a polyp, you can get a spectrum of changes, and you have to be careful with where it is, this spectrum, and where it does extend to. And then you will, believe me, the sessile serrated lesion I feel very strongly that it's coming. And I think you will see what you will, if you're sitting the exam in 2 or 3 months, it's possibly going to be there because I told you people talking a lot about it. So I'm going through it, as you can see, and I did do exactly what I did in the last case. And yes, some of you said SSL with dysplasia, right? So I wanted to show you now the example of the spectrum of things. So let's go back, because that will be a very good revision for what I have discussed with you now, okay? Let's go back again to these areas, which look serrated in the surface. But as you go below down, the crypt looks normal, okay? So if you take this section here, and I tell you these are normal crypts, you say, yes, Ali, this is a normal crypt, you're right. But the surface is serrated, and but it did not go all the way down. And look, they are a little bit spacing out slightly, tiny wee space for here. You can see that, okay? And then when I move to other areas, I want to show you the spectrum again. Lumen is irregular, but it is still okay, patent in a way when it is cross sections. So they happen as a spectrum, but then there will be areas which are a little bit dilated and it will catch the eye. I think we had good areas what we saw earlier. Here they are. Yes, look. Now, we lost that cone shape, okay? The cone is opposite now. It is actually narrow up and it is dilated down, okay? And it is touching. And look, it is gone. Where is it? Where is the muscle? The muscle is here. The muscle is here. It is gone here. This is now a submucosa, okay? And a lot of people find it difficult to understand that concept, that the lamina propria now is going into there, but it does. And in some big cases, you will find that some of the crypts will go, and some people, let's hope not in our lifetime, will be calling this as invasion because they see crypts in the lamina propria. And then they will decide that then there must be an invasion. But look, the muscle is thick here, and then it frayed. It frayed around the crypts, but the dilatation is reaching all the way down. The serration too is reaching all the way down to the crypt. You don't have to see this every feature we are talking about in every single crypt, but you assess them all together as a family. They've got a clever boy, a bad boy. They have an intelligent boy, another one. They have a very beautiful girl. They have an average-looking girl, whatever, you see. But what I am trying to say, that you assess the features together. They are in the same house. They are in the same family. And again, look at the muscle here. Now, that's a proof. And look, the crypt is becoming horizontally orientated. Where is it coming from? This must be coming from maybe this one, which has angulated. And you get some little buds coming out of these crypts. So you have some little buds that is trying. You can see some people mentioned a minute ago T-shape. You see this, if this is, you do a little bit levels here, what you will be able to see that the crypt is becoming a T shape. So you have the axis of the T here, and this is the rest of it. But what it is that by definition then, this is a sessile serrated lesion, and then some of you asked, then how do you assess the dysplasia? I think we stopped into this area. I stopped and I magnified. And look, it is dysplastic because the epithelium now is becoming darker and it is becoming a little bit more fenced. It has got here, it completely changed the characters, as you can see. Now, am I going to call this high-grade dysplasia or low-grade dysplasia? It will all depend on the complexity that you see. You see, because if you, yes, you assess it as you see the dysplasia in general. And if you think that you have a lot of cribiforming, maybe some crypts that looks a little bit more necrotic, and you have a little bit of a more height of the epithelium, then yes, okay. But yeah, there are some difference in the exam, but in real life, if I am to go back to the WHO category for how we go through this, I just wanted to highlight this a little bit more with you. So just bear with me for a minute. I will try to bring you back to the WHO slides, and then we will come back to this again. So this is the slides, okay? And what they say, that you need to say, so SSL with dysplasia, people in paper said, in actual fact, you should grade the dysplasia because you are not going to leave it like this. But the reality is that the surgeon is not going to let it go, even if you say that this is a low-grade dysplasia. So the surgeon is not going to be happy with only leaving it alone and let it go. So let me tell you what is the WHO saying about these areas, because at the end of the day, you need to go by what is the WHO said. So WHO is saying that sessile serrated lesion with dysplasia is a transient step towards the formation of carcinoma, and it's almost always well circumscribed from the surrounding areas that you see. Cytologically, it can show an epithelium that's very similar to the conventional adenoma, or it can see dysplasia that is a little bit different, with around atypical cells and prominent nucleoli and numerous mitosis, okay? And it can show you some hypermucinous change. Now, what we understand from the WHO regarding this area, so if I take you back to the slide now, let me just take you back, sorry. Here, the atypia belongs to that second line that we said, you know, that we have atypia that has got a little bit more round nuclei and prominent nucleoli and frequent mitotic activity and some hyperchromasia, some disturbed polarity, although in some areas, especially towards the surface, you might start to see a little bit of serration stratifications, but nevertheless, here, like here in these areas, you can see some stratification here, like the low-grade dysplasia, which is the traditional dysplasia that we get in the intestinal adenoma. So what I am trying to say in here into these areas that the WHO doesn't tell us to in the new classification that you have to say SSLD with the high grade or low grade. If you think that you have a lot of complexity and cribriforming and branching and secondary branching and the very high cytological atypia, then okay, call it. But if you don't, call it SSL with dysplasia. For the surgeon, it will mean the same. And what it means that in the clinical world, I am not a surgeon here, guys, but in the clinical world, what I know what will happen is they will offer the patient the hemicolectomy, if it is like in the right side, and they will say, if we are to leave it, if we don't, you know, it is very difficult for sessile serrated lesion to decide on the completion of excision. So for us as pathologists, we cannot say that. So what do you think then the surgeon will do? The surgeon will know that this is a very flat lesion. They know that it's very difficult for them during the endoscopy as well to decide if they excise it completely or not. And then the patient, it will be completely and utterly a patient choice. So the patients will have the colectomy based on your description of the dysplasia that you have given. Either if you see it as traditional way, like here, or like in the other section or the other areas which I showed you earlier, which is the one that has shown more of a prominent nucleoli and more round cells. So you have both atypia, and I don't want you to be fixed a lot into this, because otherwise it will be very difficult. I told you exactly, I read it in front of you now, what does the WHO say? And whatever the WHO say, then we follow, and this is what it is. But before we leave this area, so remember, it's a constellation of feature, and remember in areas that will look very, very hyperplastic, and in some other areas, it will look like, so it is a transition of features, and then it will flare up as an SSL, and if it continue with a mutation, it bring the dysplasia, because this is a step pattern molecular building that you need the first mutation, the second mutation, the third mutation, till you develop the full-blown cancer. But when you read about this, the other one that I wanted you to read about that comes a lot in the exam and the written OSPE is the Lynch Syndrome, okay? Yes, now I told you the SSL with dysplasia, the WHO do not differentiate between low grade and high grade, okay? So providing that the only call it SSL with dysplasia, and it will need an aggressive treatment, because the SSL tends to be multiple, and you need to resect it, because you cannot say the excision. It is in a lot of cases, the real life, okay? Let me talk to you about real life, what we see in day-to-day. In the day-to-day, if you have a large volume of cases, you will either get the patient presented with SSL only, or will come with a fecal cancer well developed, okay? It is to pick a polyp into that intermediate phase between being an SSL or SSLD, then this is a rare occurrence, right? It is quite rare, and it is a transition to cancer. So when you see, and when you look into the molecular pathway, it does not tell you, I am SSL dysplasia, high grade or low grade. If you look into the molecular pathway, they will say SSL with dysplasia will have that mutation. And then when it develops the cancer, it will acquire this mutation. And then you have the full developed, well-developed cancer. But you will need to read the pathway, and then you will understand exactly what I mean. So this polyp that I'm showing it to you now in front of you on the screen, this is not a common occurrence. this is not what you will see day to day. You might see it once a year if you have a busy service twice, but what you will see more common is the sessile serrated lesion, the one without the dysplasia. So this is to highlight this area. Okay, so I wanted to move to this polyp. There was another polyp I put, just let me find it. I think this guy here. Okay, so this guy here is it's a different one here. Look, we are keeping this tiny weeny space between the muscularis propria, but nevertheless these are not dilated at the base. Okay, one may be dilated here and angulated, but I told you it is a whole family things. Yes, it is a whole family, and the cone is still going down. Look at the shape of the cone, it's still going down. Look at the space between the mucinous cells here. There is too much space. The cells have ended. But what is in this example? You see, there is a lot of goblet cells. And if you see plenty and numerous goblet cells throughout, then this is the goblet cell hyperplasia. So the goblet cell rich hyperplastic polyp. It's not going to come in the exam, so we'll skip it very quickly. But if you feel that the goblet cells are numerous, really, really a lot. Look how many goblet cells in that crypt here. Then this is the goblet cell, and you can see that this is not dilated. They are respecting the uniformity towards the end, and the cone is correct. It is narrowing as you go lower down, and this is the hyperplastic polyp. But this is the type that the WHO said because it carries more, or it harbors more mutation. So it is good that you try to recognize it in the future for your daily, day-to-day work. So that will be good. There was another polyp that I wanted to show you. Oh, that guy. So this guy is from the left colon, and then the first look, it looked like our normal day-to-day polyp, and yes, there is a vellus morphology as well into this, with your traditional dysplasia, the fence arrangement, and you are fine, home and dry. Shall we let it go like this, or no? What is the vote? Shall we or shall we not? What it is that the question will be here that you need to make sure 100% that you are not dealing with what we will call it a traditional serrated adenoma, because there was a lot of debate about the traditional serrated adenoma in the past, and they said that the traditional serrated adenoma, it tends to have a vellus look, and some of the clever pathologists, they tend to call the traditional serrated adenoma as a filiform adenoma, you know, like a filiform, because it tends to have a little bit of a vellus look, but the epithelium can be different looking. And what it is that it's a difficult area, and I agree, because the main differential for it is the vellus adenoma with dysplasia, and some people relies on the fact that it has to have a very eosinophilic cytoplasm. This is eosinophilic, but the describe it as you must have what we call a pencilate shape nucleus that is like a very, very fine nucleus that is not really ovoid in shape in morphology. If I take you to these cells, although they have a very florid and good cytoplasm, but they tend to have a little bit of an ovoid nuclei rather than the pensile nuclei that you will see in the traditional serrated adenoma. I was not planning to go through the traditional serrated adenoma today, and this is why I did not prepare a proper example for it. But just when you finish today, just remember this look here. And I wanted you to compare the ovoid nucleus, which you see here, to the pensile nuclei that you see in traditional adenoma. The other one is a little bit more eosinophilic than this, but it still will be a filiform or vellus, so they tend to have this filiform appearance. And then the other things as well, which I wanted to highlight in this type of polyps, is the base of it, because the base in the vellus adenomas can have a lot of abnormalities, like it can have a bifurcation of crypts. It can have also branching. You can see the branching here. And when you get a cross-cut of an area like here and there, you start to get a shape which you might then tend to call it cribiforming. I just wanted you, next time you can see how abnormal the crypt looks like at the base here. Branching again, very complex branching, primary, secondary, tertiary branching. For people who are very fond of the architectural atypia as well in the assessment of the high-grade dysplasia, be careful with this assessment if you are dealing with a vellus adenoma, because in the vellus adenoma you will have a lot of complexity at the base, and this is just the nature of it. And I do find a lot of textbooks don't stress on this, and then once people start to see branching and budding and angulation and cribiforming, then they directly call it high-grade dysplasia, which I do feel that this is not right, and it should not be the case. I am not going to I think I might, oh yes, I found another one. Yes, that's the one, because I thought I found it and then I might have closed it. Look, that's a good comparison now. So I put that one now to compare. This is now our traditional serrated adenoma. In a lot of textbooks before 2019 WHO, the traditional serrated adenoma people, or big fans, as you know, it's a left-sided, and I showed you that it have a different pathway, molecular pathway from the sessile serrated adenoma. So the traditional serrated adenoma will happen more left-sided, and it will have this vellus morphology. Look, so I wasn't lying. Okay, it looks very vellus, and this will catch your eye. Okay, so once you saw that the vellus, the polyp is vellus, then hang on a second. Look, this is the nuclei that they call it pensile nuclei, and they are arranged in arrows, and they almost always look like that. They are very, very thin, and I cannot say that these are definitely ovoid. You know, they are very thin and like a little, like as if you are making a lot of lines, throwing them together, all together, and you can see they are trying to mix up, and they have eosinophilic cytoplasm as well. They are tall cells, but the arrangement of the nuclei are very good. So if you are one of those people who look at the height of the nuclei, then you will assess this and you will say, okay, might be low grade, but you go to the other areas here, and if you're very fond of this, then you might say, but it's nearly reaching the surface here, then this might be a higher grade, but that's not the case. I wanted to highlight that this pencilate look, to get, you still have to, it's a little bit hyperchromatic, but it is now, some people, if they don't see the hyperchromasia, but with this arrangement, they will call it just only traditional serrated adenoma, and some people will still call it traditional serrated adenoma with low-grade dysplasia. And if you start to see more complexity and toward in any part of it, that in the architecture, and change in the height of the epithelium and the mitotic rate and everything, you might think that that it might be a cancer, then you will call it a high grade. When I was in the first year of my training, my consultants who taught me some of the GI pathology told me, if you don't think it is a cancer, then it is not high-grade dysplasia, because high-grade dysplasia have to look exactly like a cancer. Okay, so every time you look into high-grade dysplasia, ask yourself this question: if I take this in a GI resection, would I have caused this cancer or not? But this was a good comparison. Oh, I'm pleased that I found it. But it is the pensillate nucleus, and you can see this is quite different from our normal dysplasia. My practice is, so the previous case was not traditional serrated adenoma. The previous case was a vellus adenoma with low-grade dysplasia. Okay, so I'm sorry if I didn't mention that. Okay, but here, this case is a pensillate nucleus. Let me just show you the comparison. This is the other case, I think, yes. That is the vellus adenoma. This is ovoid morphology shape. Look, they look more ovoid morphology. Look, they are more ovoid. The nucleus shape is completely different from this, right? So keep that image in your mind. Look at this. Still, the epithelium is quite eosinophilic, slightly more eosinophilic here, and you have this shape of the nuclei which look pensillate. So this traditional serrated with low-grade dysplasia. This is vellus adenoma with low-grade dysplasia, but they both share this vellus look, and this is why some people overlook it, especially in a busy service, and they don't pay a lot of attention to it, and especially if it is quite fragmented, because, okay, yeah, look, it looks vellus, yeah, it looks dysplastic, it's low grade, that's fine, but just you need to pay attention to this, because this has got more aggressive pathway and much more closer follow-up for the pathologist, for the surgeon, sorry, or the endoscopist. I will finish the section with this, which is another polyp, and the pensillate nucleus is in traditional serrated adenoma, okay? So go back tonight and read it. The traditional serrated adenoma, so going back here, the pensillate nucleus is a traditional serrated adenoma, and we say traditional serrated adenoma with low-grade dysplasia or with high-grade dysplasia, which is different from sessile serrated lesion, which we almost always say sessile serrated lesion with dysplasia. But in traditional serrated adenoma, you still have to grade the dysplasia into low grade or high grade, because the treatment will be different and the follow-up will be different, okay? So I will go to the area which I'm going to close the section with, and this is a polyp. Here, Very common case, comes in the exam a lot. So we have enough vellus morphology in some areas, but we have also some tubular morphology in other areas. And remember what I told you about that you don't judge the crypt dilatation in isolation. Yes, because if you think that this is dilated, okay, but this is still a cone shape. And I also told you in the case before last that when you have the vellus morphology, then you have to be careful with the way that you will assess the base of your crypt, because in simple terms, the vellus morphology means that the vellus is very hyperplastic. And if you are like me, was a medical student in the early 90s, then people tend to say, oh, it is the vellus adenoma that gives you the cancer, not the tubular adenoma. And as you know, this has now changed because we don't rely on this at all anymore, because both can produce tumor. But the reason why this concept was taken, because when you have villi in the surface, that means it's very hyperplastic, trying to find the space on top, and therefore it is trying to make changes like crypt hyperplasia as well at the bottom. And this is why you get this abnormal morphology. Now, what some of you said tubulovellus adenoma with pseudo-inclusion. Oh, what you left us is that the fact that you did not assess the dysplasia. And how on earth you will call it tubulovellus adenoma in the exam without telling me what grade of dysplasia do you see? Okay, and this is exactly what I meant about jumping for a diagnosis. Okay, I do not want you to be jumping for diagnosis and leave a very crucial part in the equation. Okay, so I want you first to take a deep breath and start to assess the dysplasia, because this makes a difference in the patient management more than if we definitely have invasion or not, but it is quite important. So what will give us a clue for this case will be the degree of the dysplasia that we see. Because if you are all, or you're convinced that all what you see is a low-grade dysplasia, and then you went to the center of the polyp where we have these areas, which I will visit last, then the first thing that you will go to assess the lesion will be the low-grade dysplasia or the degree of dysplasia in the epithelium which you see. Now, some of you said high grade. I just wanted you to see what you feel and tell me. Okay, I'm going through it again and again and again. And I don't want you to panic. We are not in the exam yet, but I wanted you to tell me if, take my rule, which I just told you, which I've been taught. If I am to give you this, and I tell you, this is a carcinoma, what would you say? If this is a carcinoma or not, in this gland that you see in the middle of the field now? Is that enough for you to call it carcinoma? No, right? Because the NC ratio is still low, you still have a lot of mucin production and apical mucin. So the cells are and there are some goblet cells. So what I'm trying to say, there are still some kind of differentiation. The problem is that you are trying to assess the nuclei, but the problem is that you are assessing it in the wrong place as well, because you are assessing it at the base. And at the base of the crypt, you will always find some prominent nucleoli in a lesion that's dividing very fast. And the prominent nucleolation is not really a feature of our high-grade category. It is it's almost always in the low-grade categorization. No grade, I mean, it's not a feature at all. It is the complexity of the architecture, together with the fact that if you wanted to take one feature to add it to your high grade in the large bowel, it will be the height of the epithelium, of the nucleus. If the height is reaching nearly the apical surface, then I will consider this okay. It might be a high grade epithelium, but I will only take that in consideration after I do assess the architectural complexity of this lesion. And if I don't think the architectural complexity is good enough to high grade, then I will jump to these areas, which you were dying to see from the beginning, which is in the center of the lesion. Now, textbook say hemosiderin pigment, blood, hemorrhage, mucin pools. All of these are features for epithelial misplacement in a polyp when it's get twisted. We agree, but we go, the most important, the lack of desmoplastic reactions, which is sometimes quite difficult to assess. All of these are important. The other things as well, which you tend to see is, which I feel that it's quite important, and a lot of people don't pay attention to, is here. What you see here in the middle of the field now, where my arrows going through, this is a lamina propria. And if you see the lamina propria, then this has to be a misplacement. Because in epithelial misplacement, the glands goes in the abnormal place, or it appears to be in the abnormal place, but they are taking the lamina propria with them. I just got disconnected, and I think we are back again. So I'm just making sure that it's moving. Yes, moving. Yes, excellent. So the lamina propria here is surrounding these glands, which give you a very big clue that this is epithelial misplacement. So all of the criteria matches: dilated and irregular shaped crypts surrounded by lamina propria. The epithelial lining is exactly the same like what you see in the dysplastic epithelium above. And then you can you can add the hemosiderin, the hemorrhage, whatever you wanted to add after that, and the lack of dysplasia and individual cells. All of this goes into the criteria. I did find that this was a very good case to show you this feature. But if you want to take two features to rely on out of all of them under the stress and the heat of the exam on the day, the dysplasia has to be matching exactly the dysplasia that you saw on the surface, so it's not any different. And this is not the rule in the colorectal cancer. If you go to the colorectal cancer resection, you will find that the epithelium has changed the character, and it became more aggressive, not keeping goblet cells, not doing all of these sort of things which you see in the heart and the middle of the dysplastic lesion. And then, by all means, apply all your other rules. The only rule that you cannot apply is the glands next to large caliber vessels, because that's epithelial misplacement now, and you might see some large caliber vessels into the fields where you have the epithelial misplacement. So just remember that. There's nothing that's good for all. The rules of the dysplasia for low grade and high grade varies between the different type of lesions, as we saw. The varies between the site. So the rules which we use for the esophagus are different from the rules which we use to assess the dysplasia in the stomach, and they are completely different from the rules that we use to assess in the large bowel or the small bowel. And the reason why, because in the gastric mucosa, for example, you have different type of dysplasia. You have the intestinal type, which is look like a large bowel, and you have the non-intestinal type, the other ones, the gastric type. And then you can, it's not one for all. It doesn't work like that, okay? So yes, you are absolutely correct. It's epithelial misplacement. And I just wanted to put that case to close with, because this is the common case that comes in the exam. And once again, it's not one feature, but the two most important features is the nature of the epithelium here. Does it match what you saw on the surface or not? If it does, look for the lamina propria, compare it. Just take a section into your eye from here and go to your lamina propria and see what is the nature. Look, it looks exactly the same. This is not a submucosa, all right? Your submucosa is here. This looks completely different surrounding for these glands. And these are the two secrets for these ones. I don't keep secrets in my teaching. I always tell you what the people do and how they look into these cases. And this is what I prefer to do. And this is what I will always do, because, and I want you all to do that as well, is not to be cleverer than other people, but to tell people what you know, because this is what we have to do for our patients, it's our duty. And thank you. By this, I will close this section. And thank you very much for tuning in, and thanks for listening today.